Welcome to PGOG postgraduate class in obstetrics and gynecology, and this topic is also useful for undergraduates, and it is a part of must know obstetrics series, and today's topic is fetal skull. Before we start with the fetal skull, let us know about some terminologies which are most important for an obstetrician, and it is a must know area for all undergraduates as well as postgraduates. First definition is definition of attitude. It is relationship of various parts of fetus with each other. A normal attitude is of universal flexion. Lie is relationship of long axis of fetus with maternal spine, which can be longitudinal, transverse, or oblique lie. Presentation is part of the fetus which occupies the lower pole of the uterus, so that it can be either cephalic or head, podalic or bridge, shoulder presentation, or compound presentation. Compound is if there is a hand by the side of the head, then in that case it is called as a compound presentation. Now, universal flexion indicates that there is a attitude of universal flexion indicates that there is a flexion of fetal neck, as well as there is flexion of all the joints of the upper and lower extremity with partial flexion of the fetal spine. So if there is a compound presentation, that means if there are fingers palpable by the side of the fetal head, that means there is no attitude of universal flexion. That arm has extended, and that is why it has come down by the side of the fetal head. Presenting part is part of presentation overlying the internal os of the cervix, or which is felt as a first most leading part of the fetal head or fetus when we do the pervaginal examination during labor. Depending on the attitude of the fetal head, if the head is flexed, then the presenting part is vertex. If it is neither flexed nor extended, it will be brow, and if it is extended, then it will be the face will be the presenting part. So though we say brow presentation and face presentation, these are misnomers, as actually presentation is head or cephalic, and these three are the presenting parts: vertex presenting part, brow presenting part, and face presenting part. Denominator is the fixed bony landmark which is present over the presentation. Denominator for vertex is occiput, for face is mentum or chin, and for bridge it is sacrum. Now this is most important definition: position. Position is the relationship of denominator with various quadrants of maternal pelvis, and that is why we get 6 positions: 3 on the left side, 3 on the right side, as LOA left occipito-anterior, LOT left occipito-transverse, LOP left occipito-posterior, same on the right side. So if we imaginarily we divide this cavity of the pelvis into by one vertical and one transverse line, we get 4 quadrants. So this is right anterior quadrant, this is left anterior quadrant, this is left posterior quadrant, and this is right posterior. Relationship of denominator, that means if it is a vertex is the presenting part, denominator, as we have already seen, it is occiput. So if occiput is to the right side and anteriorly placed, then it gives us a position which we will be calling at right occipital anterior. Right occipito posterior will be occiput is present posteriorly to the right side. So we call it as right occipito posterior. That is how it is the relationship of denominator. Here in this example of vertex, we are taking it as occiput. So relationship of occiput with various quadrants of maternal pelvis. We have 4 quadrants: right anterior and left anterior, and right posterior and left posterior. Accordingly we get this, and in between, if it is in the transverse occipito transverse position or left occipito transverse position. Now here, as a concept, I want students to understand that if a patient is in labor and the dilatation is more than 3 to 4 centimeters, you can palpate the fetal and you can palpate the sagittal suture also. So if sagittal suture is lying in the left oblique diameter, Now we have already seen in the last class on the pelvis that left oblique starts from left sacroiliac joint, right oblique diameter starts from right sacroiliac joint. So if it is a left oblique diameter, then there are two possibilities for the two positions which the fetal head can acquire. If sagittal suture is in left oblique arc, it can be either left occipito-posterior or right occipito-anterior. And depending on the presence of the posterior fontanelle, confirming here the posterior fontanelle is there, we can differentiate between these two. But the first thing is in which diameter the sagittal suture is present. Sagittal suture is in transverse diameter. There are two possibilities. Either it will be right occipito-transverse or left occipito-transverse position. Similarly, if it is sagittal suture is in right oblique, from right sacroiliac to opposite sided iliopubic eminence is right oblique. So sagittal suture, you are doing PV examination and you find that it is in right oblique, then there is a possibility either fetal head is in ROP, right occipito-posterior position, or it is in left occipito-anterior position. That is why it is important to understand this concept of position before we proceed with the various in detail about the fetal skull, and then next class we will be having mechanism of labor also. So this forms the basis. So again, you go back if you want revision, go back to this same slide, but there should not be any doubt about that what is why in right oblique you have LOA and ROP as two possibilities of the position. That is commonly asked question in examination, that if the sagittal suture is in right oblique, what is the possibility? What will be the position? Your answer should be there are two possibilities. Either it can be left occipito anterior or right occipito posterior position. Palpation of the posterior fontanelle, anterior fontanelle will further help us to differentiate between these two. Now we start with fetal skull. Fetal skull has four regions, four sutures and two fontanelles. Four regions are vertex, occiput, sinciput and face. Four sutures are sagittal suture, coronal suture, frontal suture and lambdoid suture. Two fontanelles are anterior fontanelle, which is also called as brecma, and posterior fontanelle. Now, what is vertex? That is a very commonly asked question. What is vertex? Vertex is a quadrangular area which is bounded anteriorly by anterior fontanelle and coronal suture, posteriorly by posterior fontanelle and lambdoid suture, and laterally it is bounded by the perpendicular lines passing through the two parietal eminences. So this is one parietal eminence, this is other parietal eminence, and perpendicular lines passing through these parietal eminences form the lateral boundary of the area which is called as area of the fetal skull, which is called as vertex. So this is vertex, and the sagittal suture is running at the center of the vertex. This is the anterior fontanelle with coronal suture here and a frontal suture there, and the on this side is the sagittal suture. So four suture lines are meeting with each other and it is forming a gap here, which we call it as brecma or anterior fontanelle. Posteriorly, at the junction of the lambdoid suture with the sagittal suture, we have a fontanelle which we call it as posterior fontanelle. So this anterior posterior margin and the lateral margins together form this area of the fetal skull, which we call it as vertex. Other regions are sinciput or the brow is the area which is bounded superiorly by coronal suture and inferior and anterior fontanelle and inferiorly by supraorbital ridges. Occiput is the area which is present over the occipital bone, so that it is posterior to lambdoid suture till nape of the nape. Face is the area below supraorbital ridges. Now coming to the sutures, sutures are the gaps between skull bones, as skull bones are non-ossified at the periphery. Sagittal suture is the gap between parietal bones. It is extremely important when we do pervaginal examination in labor. When most of the time what we are palpating is the sagittal suture, which helps us to determine the attitude of fetal head, whether it is flexed or extended. It helps us to determine the position also, where whether it is a occipito anterior, posterior or transverse position, right sided or left sided position. It also, sagittal suture will also helps us to know the internal rotation, which is the important movement in mechanism of labor. So it is extremely important suture as far as our obstetric examination goes to assess the progress of the labor. Coronal sutures, these are separating parietal bones from frontal bones. Lambdoid suture separates parietal bones and occipital bone. Frontal suture is the suture in between the two halves of the frontal bone. This frontal suture gets as ossified by curve. Now, fontanelles are where the suture lines meet with each other and a larger area or a gap develops. That we call it as fontanelle. Anterior fontanelle is also called as bregma. It is diamond shaped with 4 suture lines meeting here, one of frontal suture, 2 of coronal from 2 sides, and one of sagittal suture. It is a definite gap of 2.5 by 2.5 centimeters in size. It will be palpable. Anterofontanelle, if it is palpable very easily, it indicates that fetal head is a deflex head. It is not a well flexed head. So that is how it helps to decide attitude of fetal head. That means how much is the flexion in the fetal head. That is the attitude of the fetal head. That is determined by if we can palpate the anterofontanelle, it indicates that easily palpable anterofontanelle is indicative of a presence of deflexed head. On the other hand, posterior fontanelle is triangular in shape. 3 suture lines meet here. There is no actual gap because it gets ossified by the time fetus is a term fetus. It is easily palpable in, but you can appreciate a depression here. It is easily palpable whenever it is a flexed head, and it helps in confirmation of position. As I said, if the, for example, if posterior fontanelle is to the left side anteriorly, it indicates that it is a left occipito-anterior position. If it is to the right side transversely, it confirms that it is a right occipito transverse position. So wherever posterior fontanelle is, we know that in its close proximity will be the occiput, and that is how it helps us to confirm the position of the fetal head. Now coming to the important part of anterior-posterior diameters of engagement of fetal head. As the fetal head or fetal skull or fetal head engages, there are 2 diameters of engagement. One is antero-posterior diameter and other is a transverse diameter. If vertex is the presenting part in a cephalic presentation, and if the attitude of the fetal head is of complete flexion, then the antero-posterior diameter of engagement is suboccipitobregmatic diameter, which is 9.5 centimeters. Subocciput is a point below the occipital protuberance, just below the occipital protuberance, and bregma is the center of the anterior fontanelle. So from this suboccipital point to the bregma is a suboccipitobregmatic diameter, and it is the shortest diameter of antero-posterior diameter of engagement, that is 9.5 centimeters. So complete flexion that way tells us that it is complete flexion is the attitude of choice for easy vaginal delivery. If it is incomplete flexion, which is so many times present in at the start of the labor and then flexion gets completed. So with incomplete flexion, it is suboccipitofrontal diameter from same point posteriorly to the anterior-most end of this bregma or anterior fontanelle is the suboccipitofrontal diameter, which is 10 centimeters. But if there is a marked deflection, deflex head is present, then the diameter changes to occipitofrontal. Frontal here is glabella, that is the point, and posteriorly it is the occiput. So occipitofrontal, that is a larger diameter, which is 11.5 centimeters, and here we can understand that why deflex head is the commonest cause of non-engagement of the fetal head. Any condition which promotes or which leads to deflection of the fetal head, deflex head, such as occipito-posterior position, or if there are multiple loops of cord around neck, which is preventing the flexion of the fetal neck, whatever changes this attitude of universal flexion and leads to the deflection of the fetal head, deflex head, it will lead to larger diameters being presented for the engagement, and it might lead to a difficulty in labor if the head remains persistently reflex, because diameter is more by 2 centimeters. It is significant. Suboccipitobregmatic is 9.5, whereas occipitofrontal is 11.5 centimeters. If bro is the presenting part, then the largest diameter of the fetal head is getting presented, which is called as mentovertical, from tip of the chin to the highest point over the sagittal suture. That is mentovertical, and this is 14 centimeters. And as we have already seen in the last class on the maternal pelvis, largest diameter of the maternal pelvis is 13 centimeters, which is transverse at the inlet and antero-posterior at the pelvic plane of pelvic outlet. No diameter is greater than 13 centimeters, and so that is the reason if it is a persistent bro presentation with an average size baby, vaginal delivery is not possible. So if you are asked which is the largest diameter presented to the maternal pelvis of the fetal skull, your answer should be mentovertical, which is seen if there is a bro presenting part. It is the longest diameter. If it is a face is the presenting part, and if it is a completely extended attitude, then the diameter of engagement is favorable. It is submentobregmatic. Now, submento point is that it is at the junction of the floor of the mouth with the neck. This is the point I am showing. So it is the point at the junction of floor of mouth with the neck, and from this point to the center of the bigma is submentobregmatic diameter, which is 9.5 centimeters. But if, as in the this attitude of flexion, similarly here also, if extension is incomplete, then the diameter changes from submentobregmatic to submentovertical. That is same point, junction of the floor of mouth with the neck to the highest point over the sagittal suture. That will be submentovertical, which is 11.5 centimeters. Here you can see mentovertical is 14 centimeters, submentovertical is 11.5, and the shortest possible is with complete extension, it is submentopragmatic. Coming to transverse diameters of engagement of fetal skull, biparietal diameter is the diameter of engagement. Joining the two parietal eminences with each other is the maximum transverse diameter of the fetal skull, and it is 9.5 centimeters, and this will be the diameter of engagement if it is a synclitic type of engagement. We have already seen in the last class on the pelvis, and those who have not gone through that video, please go through it, because I have explained in detail what is synclitic synclitic engagement. Then if you are asked what is the diameter of engagement in a synclitism or synclitic type of engagement, your answer should be biparietal diameter, which is 9.5 centimeter. On the other hand, if it is asynclitic, diameter of engagement reduces by 1 centimeter. It is super subparietal diameter, which is 8.5 centimeters. It is from a point above the parietal eminence on one side to the opposite side, point below the parietal eminence on the opposite side. This is super subparietal diameter, which is 8.5 centimeters, and it is the diameter of engagement whenever the type of engagement is asynclitic, where one parietal bone descends down followed by the opposite sided parietal bone, that is asynclitic engagement. So in coming to the diameters in short, antero-posterior diameters of engagement, if it is a vertex is what? Vertex is not presentation. Here presentation is cephalic presentation. Vertex is the presenting part, because it will be the part which will be felt for the first time when patient is in labor and we are doing parvaginal examination, and it is the part which is overlying the internal os of the cervix. So if vertex is the presenting part, attitude of the fetal head is of complete flexion, then diameter of engagement is suboccipitobregmatic diameter, which is 9.5 centimeters. Now, for our way of understanding, complete flexion, complete extension, both are favorable. So if it is face, as far as diameters goes, though there are other problems with the face, as there is hardly any molding possible with the face, and that is why even with this diameter also there sometimes can be a problem. On the other hand, with the vertex there is a molding, that is one suture, a suture is getting obliterated, one skull bone is overriding over the other, which reduces the diameter, which is less likely with a face presenting part. But if it is a complete extension as vertex complete flexion, remember 9.5 is the suboccipital-bregmatic. Similarly, face complete extension, it is submentobragmatic, which is also 9.5. So for the ease of remembering, to memorize it, I have shown it like that. That suboccipitobregmatic, submentobragmatic, both are 9.5 centimeters. Suboccipitobregmatic is with complete flexion, submentobragmatic is with complete extension. On the other hand, if it is a deflex head, the diameter changes to occipitofrontal diameter, which is 11.5 centimeters. And if it is incomplete extension, it is submentovertical, which is also 11.5 centimeters. So it is easier to remember the diameters this way, that complete flexion and extension 9.5 centimeters, deflection and incomplete extension is 11.5 centimeters. In between, we have here for the vertex, there is one incomplete flexion, which is suboccipito frontal diameter, and it is 10 centimeters. If it is a brow is the presenting part, then the diameter of engagement is mentovertical, which is the longest diameter. It is 14 centimeters. Transverse diameter, biparietal diameter, we have another 9.5. So how many 9.5? I have marked this as blue. That suboccipitobregmatic is 9.5, submentobragmatic is 9.5, as well as biparietal diameter is also 9.5 centimeters, which will be the transverse diameter of engagement in a synclitic type of engagement. Or synclitism, diameter of engagement changes to super subparietal diameter, which is less. It is less by 1 centimeters. It is 8.5 centimeters. Thank you so much.